Hello and welcome to our training video. My name's Natalie Morgan. I'm a podiatrist. I'm also the lead in the workforce development component of the Walk Strong, Walk Tall team here at SAMRI.
And I'm Bonnie Hammond. I'm an Eastern Islander and Tanana woman, and I'm the leader of the community arm, the community engagement for the Walk Strong, Walk Tall team.
We're filming this video today in the SAMRI building on the lands of the Kaurna people, and we would like to acknowledge the Kaurna people as the traditional custodians of this land. We also acknowledge their continued connection with the land waterways of the region that we call home. Today, we'd like to talk to you a little bit more about the offloading kits. Hopefully you've received one of these offloading kits at your health centre. These offloading kits have been made possible by funding from the Australian Federal Government as part of the Walk Strong, Walk Tall team, which is the South Australian Aboriginal Diabetes Foot Complications Program. Our program is just about to come to an end, but hopefully you'll be able to utilise these offloading kits within your workplaces into the future. First of all, we'd like to go through the contents of the offloading kit. You'll see the lovely big box. Inside the box, we have some wool felt. We also have some post-operative shoes. We have those in the Darko brand in a small, medium and large. We also have the knee-high offloading boots. These are Opal brand and you'll see those in a small, medium and large. We also have an Even Up and again in a small, medium and large. Hopefully you also received in the deliveries some beautiful stickers that you are more than welcome to utilise in your clinic as you see fit. Some of you will also have some scissors and also have some bush rough. We have in the kits some booklets. There are two options of these booklets. They look the same on the outside, but they have slightly different contents on the inside. These booklets have been developed to a local context, which is why they have slightly different information. In South Australia, we have two main tertiary hospitals which accept the high-risk foot. So the two booklets reflect those two tertiary hospitals. It's the Royal Adelaide Hospital in the central part of metropolitan Adelaide and Flinders Medical Centre in the southern suburbs. Each region that you work in will have direct networks with one of those hospitals. So we rely on your understanding of which hospital to go to. Patients do, however, have a choice of which hospital to access, and that comes into consideration when making referrals. When you open the booklet on the page, it will have a phone number, and this phone number is into the high-risk foot service of those tertiary hospitals. So for the Royal Adelaide, it's called the Central Adelaide Local Health Network, often referred to as CARLN. At Flinders Medical Centre, that's in the Southern Adelaide Local Health Network and often referred to as SARLN. So the contact phone number and the contact email addresses are there for escalation into the high-risk foot services relevant to your region. So these offloading kits are utilised in high-risk diabetic foot care. Unfortunately, in Australia, there is a minor or a major amputation as a direct result of diabetes every 2 hours. It's been the purpose of our project to try and help community avoid this unacceptable statistic. Having an amputation as a direct result of diabetes has a huge impact on the individual's family, their community, and the wider health system. So we really want to prevent any amputations and make life a little bit easier for those people that have experienced it. Okay, so when assessing a patient's foot health, for their diabetes risk status, we often refer to this pathway. If you were at any of the Look at Me training throughout our project, you would have seen this chart before. It is downloadable from the internet at Foot Forward. We can supply the links to this chart in a separate email that we'll forward to you. If you follow this chart, we are looking for signs of peripheral vascular disease, otherwise known as peripheral arterial disease, and the abbreviation for that is PAD. We're also looking for sensation, and the abbreviation for that is loss of protective sensation, otherwise known as LOPS. They're the two things that we'd always be looking for when we're looking at a patient's foot when they have diabetes. So when assessing for PAD, we are looking at the pulses. We're looking at the dorsalis pedis pulse and the posterior tibial pulse. Courtney here is going to be our patient for today, and I will just demonstrate how to palpate those pulses. Thanks, Courtney. Is it okay if I touch your foot today? Yeah. In a clinical setting, which we are not here today, we're pretending to be actors today. So some of our infection control will be modified, but I would like to put on my gloves just for the infection control of both Courtney and myself today. The dorsalis pedis pulse is on the top of the foot. We're looking at in between the big toe and the second toe, and then going down to over the arch. And when I feel Courtney's pulse there, it's lovely and bounding. So for Courtney here today, I don't think she has peripheral arterial disease, but that's one of the spots that we'd be looking for. We also come around to the posterior tibial pulse, otherwise known as the inside ankle pulse. So we're looking for the medial malleolus, or inside part of the ankle, and we're trying to feel just behind that medial malleolus. And again, I can feel Courtney's pulse very, very easily. So yet another confirmation that I don't think Courtney has peripheral arterial disease. Other things we're looking at when we're assessing peripheral arterial disease, we're looking for the temperature of a foot, we're looking for the colour, and the colour should be very similar to a person's hands. We're looking for skin texture, and we're looking for hair growth on feet, and we're looking for the condition of the nails, all trying to see if the foot's lovely and healthy and being supplied with a very nice source of blood supply from her artery. When assessing for loss of protective sensation, our gold standard tool is the monofilament. Again, you would have experienced seeing this in the Look at Me training. But just for a refresher, when we're looking to assess loss of protective sensation, we're looking at 3 points on a foot, and we're utilising a monofilament. A monofilament is a piece of plastic cut to a really particular length. When utilising this in a clinical setting, I'll always ask for consent. So Courtney, is it okay if I use this monofilament just to assess how sensitive your feet are today?
Yes.
Can I use it on your hands just so you know what to expect? Can you feel it when I touch your hand? Yeah. When I'm touching Courtney's hand, it's a very light touch, and I'm just looking for that shaft of the monofilament to slightly bend. So is it okay if I try that on your foot now? Yeah. When I do it here, I'm going to ask you to close your eyes and just tell me when you feel this touch your foot. Yep. Yep. Beautiful. Thank you. Courtney could feel that at the 3 points, which indicates that she does not have a loss of protective sensation. Her nerves are still telling her very well what's going on down at her foot. What we often see in diabetic foot disease, though, is changes to the peripheral circulation and changes to the peripheral nerves. One of the highest risks in loss of protective sensation is trauma can occur to the bottom of the foot and the nerves, and doesn't tell the person what's happened. This time of year, with summer at the moment, and very, very hot, you can have injuries on a foot from things like walking on asphalt in very, very hot temperatures and get burns on feet. Or we can see stepping on glass, stepping on metal objects, or even when someone doesn't have loss of protective sensation and they're wearing their thongs in summer, they may not feel that the bar in between their big toe and the one next to it has rubbed into a blister. So that's the main cause of foot injuries that we see. People don't feel direct trauma to their feet. And this is what is so important about the offloading kit. When someone does have a diabetic foot wound, we really want to protect that whole foot from further damage. And why it's called offloading, we want to take the load away from a wound or a sore on someone's foot. I'm going to draw a mock wound on Courtney's foot so you can see what I mean. We're going to imagine that Courtney's got a very big blister underneath the big toe joint of her foot. So I'm just drawing a mock wound with the red texture on there. So if this had started as a nasty blister, Courtney had bought a brand new pair of shoes, worn them out to the cricket, didn't feel that pair of shoes was rubbing a big blister, got home, the blister burst, and we have the start of an ulceration. In terms of wanting to prevent that becoming infected or gangrenous, we want to take the load off of that area. So some of the contraindications of using some of the products here, if that wound is severely infected and the infection is such that it's at risk of Courtney's systemic health, we need to follow the steps within the active foot disease pathway. You'll find these in the booklets attached within the offloading kits. Those, if a foot is infected, it may need to be escalated into a high-risk foot clinic. And if you're not sure, you can ring the phone numbers or take a photo of the wound and access telehealth via the details in that booklet. But we're going to say it's not infected today. I'm also going to ask about other risk factors for utilising these tools in the offloading kit. All of it has to be consented. So whatever I put on Courtney's foot, I'm going to check that she says yes, and that's okay to utilise these treatment. Assuming, Courtney, it's okay you're happy with what we're going to do today. So the gold standard, the most weight is taken off a foot when we use the offloading boots, the knee-high offloading boots. In this case, I would be applying my wound care, depending on what was clinically indicated. And we all know that you're awesome at wound care, so we're not going to be focusing a lot on wound care today. But we would be putting a primary antimicrobial dressing on this wound, a secondary dressing over the top of that, cleaning the rest of the foot, and then utilising a knee-high offloading boot. There are instructional videos on the internet, and we've put a QR code in the front of the booklet where you can go to the internet and see these in more detail. But we're going to run through putting one of these on Courtney now. It'd be easier to do this in more of a seated position. Key thing with these boots is that it doesn't matter if trousers are in or out, depending on what the patient is more comfortable with. The back of the heel needs to sit very deeply within the back of the boot. And then we close the flaps. We always start with the strap that's closest to the ankle. That's where we get most control out of the offloading boots. So we do that strap first. And then we work along the others. This boot happens to be a little bit too big for Courtney's foot, but I think you'll get the understanding. Once that's on Courtney's foot, we'd get her to stand up and we'd just check that those Velcro straps are holding in position. And I'd come back and just check that the ankle strap right it is the most firm. We may need to re-secure that Velcro over the ankle. Courtney, I'll get you to put your foot up there and I'll just double check. So it's this strap here, immediately over the top of the ankle. That will come back and just check that that's firm enough. All right. The thing with these boots, they can be hot. They can be cumbersome. So we're also wanting to be checking, Courtney, have you had any falls in the last 12 months? Having had a fall recently is one of the contraindications for utilising these boots. In that case, it may be too dangerous. These may place the patient at more risk of another fall. So we take that into consideration. The other thing is that these boots are very hot. So in climates like it is in South Australia right now, very warm, a patient may not consent to wearing one of these boots because of the temperature. At the end of the day, consent from a patient is everything. And if a patient does not consent to wearing one of these boots, there's no reason to persist. There are other options for offloading. But a wound on the plantar surface or the bottom of someone's foot, we really need to get the weight off of it. And this is the best modality, best treatment we have to get weight off of that wound. I'm going to take this off now, and then we're going to move through some of the other options. So these boots can be removed quite easily by the patient. In some settings, they have been utilised and become an irremovable boot. In that case, the orthotist or the prosthetist in the hospital, or even the podiatrist, doctors, nurses, can utilise the fiberglass bandaging that you'd utilise in a fracture clinic, and you can wrap that around the boot to make it irremovable. Again, you would need patient full consent to do that. If a patient was happy with the boot, but was very worried about feeling uneven with their walking, that's why we've placed the Even Up in the offloading kits. This is a product which has a lot of layers, and you can play with those layers to get the right height that you need. This goes on the uninjured foot over someone's shoe so that they can walk in a more even manner.
Will it work on the thongs? Maybe not.
No, it doesn't work so well on thongs, as we'll see. We sort of need some kind of it's possible to try it. It's not suggested to utilise on a pair of thongs. We'd be much happier putting it on a pair of sneakers or a closed-in shoe. But where there's a will, there's a way. What do you think, Connie?
Yeah, it looks great.
Yeah.
But it does feel good.
Yeah. All right.
And be perfect on sneaker.
So the other part of the offloading kit is that we have the Darko surgical shoes. These small, medium and large is the next best option. If someone doesn't consent to the full knee-high boot, we can utilise these. Even these used just on their own can be very effective. You'll feel that they're very, very stiff and you cannot move the sole of these shoes. Just by putting that on someone's foot, we stop the pivoting off of that wound. So even just on their own, they do provide a high degree of offloading to a wound. These can be very versatile. They have a layer that the Velcro all separates. They're the same left and right, and that goes for the knee-high boots as well. We don't need different ones for left or right. They just need to be the right length for the person's foot. Once all the Velcro is away, you find they have a layer that comes out. This layer can be very useful in some of our offloading tools as well. The other thing we have in the kits is the felt. These come in big sheets like this. When it's like from here, we need to cut it into position. It's very easy to cut, but you do need a very good quality pair of scissors. Dressmaking scissors are ideal. So if you have a pair in your kit, that's great. If not, they can be sourced from all dressmaking supply stores to get some very good quality scissors. When the felt is ideally in position, we want to imagine where we're going to put it so that we get the most weight coming off that. In the situation that a patient consents, and we need to talk about the patient's lifestyle in deciding whether or not we're going to stick the felt to person's foot or whether or not we're going to stick that into the boot. What do you think, Courtney? Would you prefer to have felt stuck to your foot or would you prefer to have it stuck inside the shoe?
I don't mind. Mate, is there a benefit either way?
So the benefit of having it stuck to your foot is that it's there. You don't need to reach down. You don't need to take it on. You don't need to take it off. If we want you to be in the boot the most of the time, but if you do sneak around with just a pair of socks, you're still going to get a lot of offloading benefit from the felt. The negatives of sticking it to your foot, as soon as you get it wet, it's going to need to be changed. So if we have a big downpour and it's wet in the environment, it's going to need to be changed. If you have a shower, we can try and keep it dry in the shower, but obviously it might get a little bit wet in a shower and then you'd need to change it. So I'll show you the two options. I'm going to stick it to your foot first.
Yep.
So when we're sticking it to Courtney's foot, we're looking at the parts of the foot which take weight. So we know a lot of weight gets taken through the heel and then a lot of weight gets taken through the ball of the foot. Because in most people with diabetic foot wounds, they've lost a little bit of their sensation. We don't want to remove too or add too much bulk underneath the heel, but we do want to stop that front of that foot pushing off that wound. So it's from the arch area to the ball of the foot that we're looking to take more weight and alleviate it off of that wound. So I'm going to get the rough shape of Courtney's arch. Curves are great when it comes to felt. You'll see that it starts off with very angular edges, but I'm wanting to make as many curves as possible, just like the human foot. Here, I'm going to cut out an area that's the same size as the wound and double check that it's right. Once we're at this position, I need to take those sharp edges away off of the felt. I don't want to see 90 degrees. We want to see lovely curves. To get that, hold the scissors at a 45-degree angle, and we're going to cut that hard edge off of the felt. So I'm going all the way around. Now, if we were doing this felting on someone that lived in an area that it was accessible to come into clinic, for instance, once a week, and they were able to keep their foot dry, we could put the felt on once a week. And if they did have a family member, or if they were able to themselves, or there was a Aboriginal health practitioner, a remote area nurse that could do the dressings in between, we can keep the felt in place and dress around that. In that case, we'd be sticking the felt on the foot, clearly sealing it around with Hyperfix or a similar product, and then applying the wound dressing. The wound dressing can be changed and the felt can stay in place. Or you can do it all in one, depending on the circumstances of the person in front of you. So the felt has a self-adhesive backing. We peel that off and then we can stick it directly to the foot. One of the other risks or contraindications that we need to consider is if someone has an allergy to the sticky used in this felt. So asking someone if they have ever had an allergy to sticky plaster is useful. And in that case, we wouldn't be sticking it to their foot. We would elect to stick it in the shoe. So in that case, we can use that in combination. So with the felt, that then goes into the post-op shoe, securing the Velcro. There we have it. So these are designed to only be utilised on the foot that has a wound. Often patients would like to have a matching pair and have this on the good foot. But when I described how stiff these shoes are, they really stop someone's foot from moving in its normal angulation. So patients putting them on both feet will find it very, very challenging to walk. It transfers weight directly back to knees and hips. So patients will find them very, very uncomfortable. So ideally, only utilising the post-op shoe on the foot that is wounded. The liner on the inside, we can utilise that for offloading. This is an example which I've done earlier. I've cut the felt out in a very, very similar way, but I've stuck that to the liner of the post-op shoe. That way, that this can be a lot more durable. The patient doesn't need to be so careful with keeping their foot dry or keeping the felt dry. So a much more long-term option for offloading of a wound on the plantar surface of the foot. Courtney, do you have any questions in regard to what I've done to your foot today?
No, I think as a patient, maybe I would just ask how often I need to come back or when I need to come back, and what to do if the felt came off before I had planned to come back.
So ideally, if we're sticking felt to someone's foot, we really would like to see them in clinic once a week, where we can take the felt off, we can clean the skin, we can clean the wound, we can debride the wound, we can assess if the dressings and our offloading is being successful. The more that wound heals, we can start to stretch out that interval in between appointments. If you've got a family member at home, Courtney, that is able to help you, the felt is a very safe modality. It's very hard to hurt yourself with this felt. So if you've got someone at home that can help you or you feel confident doing it, I'm happy to give you some felt to take home with you. We can cut it into shape here in clinic, or I can show you how to cut it and you can do a little bit of that yourself. But ideally, coming back to the clinic once a week to get it changed. If the felt comes off and you don't have any options at home to redo the felt, just wearing the offloading boot in the shoe or the boot is still very, very helpful and a much better circumstance than going barefoot or going back into your old shoes. Right? So if you notice that wound getting worse at home, very, very important to come back into the clinic. So we're looking for signs of infection. The signs of infection are if your foot becomes much more swollen, if it becomes a different colour, if we find any fluid coming out of that wound, or if you're feeling very unwell within yourself. Those feelings of being unwell in yourself can be having the shivers, but then feeling hot, feeling like you're going to be sick, so nausea, or if you're able to check your sugar levels, if your sugar levels rise very, very quickly, that can be a sign of infection. And always check in with the clinic. Yep. Thank you, everyone. I hope this video has been helpful. We would love to get any feedback and we'll send the email contact here at Wadley Paringa at SAMRI to receive any feedback that you have down the track. Thank you.